Good morning, everyone, and welcome to the Building a Culture of Health virtual town hall. My name is Darren Anderson, and I'm with the New Jersey Partnership for Healthy Kids and the New Jersey YMCA State Alliance. We are honored and grateful that you're attending this event here with us today. There are over 800 registrants joining us to talk about the important topic of COVID-19. Where do we go from here? And the exacerbated impact social determinants of health is having in our communities. I would like to thank our sponsors for today's town hall. We have the New Jersey Department of Health. We have the Robert Wood Johnson Foundation, the Nicholson Foundation, RWJ, Barnabas, New Jersey Health Initiatives, Horizon Foundation of New Jersey, Ware Care, Health Plans, Nova Nordis, New Jersey American Water, Russell Berry Foundation, the Burke Foundation, New Jersey Division of Disability Services, New Jersey Hospital Association, American Academy of Pediatrics in New Jersey, Partners for Health Foundation, PNC Bank, Salem Health and Wellness Foundation, and the New Jersey Relay and Captel Group. I also would like to thank today's planning committee for their tireless efforts and to help this town hall to become a success, and their flexibility in pivoting, turning a planned in-person event into a virtual one. You can see the names scrolling here on your screen. So we'd like to thank them once again. Today's discussion will feature a town hall conversation in the first hour and a panel of experts in the second. To optimize your virtual experience, I urge all of you to set your Zoom speaker view. You will be able to ask questions through the Q&A function, and the chat feature can be used for visible discussions and comments. Before I introduce our town hall moderator, Dr. Chris Purnell, I would like to take a moment of silence to recognize and acknowledge those that lost their battle to COVID-19. This conference will miss the presence of our population health champion, friend, colleague, Colette Lamotte-Gillette. For those that knew her, she was a beautiful soul, was deeply committed to health equity. She most recently worked as a senior program officer with the Nicholson Foundation. And for 15 years, she served as the first director of population health at the New Jersey Department of Health. In recognition of her enormous contribution and legacy, the state established the CLG after the initials of her name, Community Health Worker Institute, and dedicated it to her memory. Colette was a public health champion, a hero, and will be dearly missed. Let us all continue to honor her by doing the good, socially good work. May we please pause for a moment of silence. Thank you all. And for those of you in which COVID is personal, because of a loved one or a friend, we also take this time to honor them as well. And now I have the pleasure of introducing our moderator for our town hall conversation. We have Dr. Chris, is what she's affectionately known as. She's a dynamic physician leader, health and wellness visionary, and social change agent. In her public health practice, she concentrates on health justice, community-based advocacy, and population-wide health promotion and disease prevention. Recently, she joined University Hospital in Newark, New Jersey, as the first Chief Strategic Integration and Health Equity Officer, where she oversees a portfolio which includes population health, strategic planning, community affairs, and the human experience. Dr. Chris attended Princeton University and Duke University School of Medicine. She received her MPH from Columbia and completed her residency at Johns Hopkins. She's a fellow of the American College of Preventive Medicine and holds an appointment as a clinical professor at the Rutgers, New Jersey Medical Schools. So without further ado, I welcome and introduce our virtual audience to Dr. Chris. Dr. Chris.
Good morning, everyone. It is my immense pleasure to be before you this morning to help us center our conversation around New Jersey's response to what has been an unprecedented public health crisis, and to think about those factors that have driven the outcomes that we've experienced, what we've learned to date, and what we could perhaps do differently going forward. I like to say that lived experience, that storytelling, the use of narrative is one of the most powerful formats in media to express a sense of urgency, to plain speak in a way that everyday people can understand what's happening and what's going on. And so I'll begin with a personal story of my own. It's known to many of you that the epicenter of the coronavirus pandemic landed on New Jersey in the region this past spring. It even, in more specific terms, landed in Newark, New Jersey, here at University Hospital where I work. But it also landed on me personally. On April 13th, 2020, I lost my beloved father to this pandemic. In addition to losing my father, my sister, who is a breast cancer survivor, is what we call a long hauler, and some 8 months later is still recovering from her coronavirus infection. And finally, I just lost a beloved cousin to complications of coronavirus and attended his virtual services just yesterday. I give you that story because it's so important to put a face to the data, to put a face and a name to the science so that we understand the true motivation and goal to get us all healthy and to make sure we're all safe and we're all well. In this conversation this morning, I'll be joined by two esteemed colleagues. We'll have Dr. Richard Besser, who is the president and CEO of the Robert Wood Johnson Foundation, past acting director of the CDC, and also we'll be joined by our beloved commissioner, Judy Persicelli, here at the State New Jersey Department of Health. So I'm looking forward to a very robust conversation, and we'll begin with a little bit of what I said. So I like to describe what we're experiencing to both of you as two pandemics, the collision of two pandemics. One pandemic being that fast pandemic, the coronavirus infection, the novel agent that seemed to burst onto the scenes last December, and the other being that slow pandemic, that pandemic of systemic racism. And it's the collision of those pandemics that unfortunately have made this crisis even more devastating, even more unprecedented. And we've seen disproportionate burden on Black and Brown communities across the United States and in New Jersey. Could you react to that premise, the collision of two pandemics? Dr. Besser, we'll start with you.
Thanks very much, Dr. Chris. And first, thank you for sharing your personal story. I think that it's far too easy, as we hear right now, that more than 3,000 people are dying every single day, to get numb to this crisis, and to think that these are just numbers. But hearing your story, hearing about what an incredible colleague people lost back in April, it makes it real, and hopefully gives people the motivation to take action and not be just numbed into inaction. You know, I think your premise is spot on. I talk about actually a third pandemic as well, and that's the pandemic of this economic crisis. And when you look at these three tangents that are moving forward, the long legacy and ongoing impact of structural racism in our country, this pandemic of COVID, and then the disparate impact of the economic crisis. It's clear why, while every community is being hit by COVID, not every community is being hit the same. And When you look at the national data, Black Americans, Latino Americans, Native Americans being infected, hospitalized, and dying at 3 times the rate, in some areas much higher than that, of white people, far surpassing their proportion of the population. And when I hear reports, it's like, wow, if people would just change behavior, if people would just do this and do that, it ignores the critical role that structural racism plays in this. And early on, the discussion was so much around, well, does it have to do to different rates of heart disease and lung disease and diabetes? But more and more, the analysis is coming down to differences in exposure risk. I feel extremely privileged that I can do my job from my basement here in Princeton, New Jersey. I don't have to leave the house to do my job. And I have accumulated resources so that if I had to work but didn't feel well, I could stay home and afford to. But when you look at how that plays out around the country, a far greater proportion of people of color are in jobs that require frontline interaction, whether it's in healthcare or food production or transportation. There's just so many jobs that you can't do remotely, and a higher proportion of people of color would fall into that group. And then when you look at the wealth differential in America, where white Americans have 10 times the accumulated wealth of Black Americans, it means that for many people, they're being forced to make a decision between, well, do I go to work so I can put food on the table and pay the rent? Or do I stay home so I can protect myself and my family and my community? So I think the way you lay this out is critically important. And my hope is that, because we have the collision of these 3 things at the same time, that will motivate us not to just say, wow, that's just bad, that shouldn't be, but motivate us into action and to policy change, and to say, the movement for racial justice, the recognition of the disparate impact, gives us a moment in our history where we can actually affect change on this.
Thank you for that. Commissioner, could you weigh in on that premise as well and drill down on what we've seen across our state?
Sure, thank you. And thanks everyone for the invitation this morning. And Dr. Besser, it's always great to share the screen with you. Dr. Besser is the head of the Governor's Health Restart Commission. So I get to see him on the screen regularly. New Jersey's been hit hard. Just to level set, March 4th, we had our first case. On April 14th, we had 8,300 cases in our hospitals. Today, we sit here and 16,000 New Jerseyans have succumbed to this disease. Non-Hispanic Black men are dying at a rate 2.5 times greater than white Americans. And non-Hispanic men are 3 times as likely to die from this disease. So I'd like to use the analogy of the mask. We're telling everyone to put on masks. In this particular situation, this pandemic has unmasked what we all know has existed for years. The institutional racism that we've been dealing with, and all of you know that I've worked a really long time in healthcare in New Jersey, is coming to light. So what did we do with the Department of Health? Well, first of all, I have to say that Dr. Besser was the guiding light in making sure that we never lost sight of the fact of this disproportionate impact on communities of color, encouraging us every step of the way to put that foremost in our lens. So the first thing we did was look at testing. We ramped up testing in urban centers of Elizabeth, Patterson, Newark, Trenton, Atlantic City, and Camden. And then secondly, we looked at our homeless population. Our homeless populations in Asbury Park, Atlantic City, Camden, East Orange, Newark, New Brunswick, Newton, Jersey City, Patterson, and Trenton all got the benefit of work that Natasha Rosario spearheaded to make sure that they were able to get tested. We identified all the vulnerable populations and brought mobile testing sites into our urban centers. And then we looked at isolation and quarantine. As Dr. Besser pointed out, if you cannot appropriately isolate or quarantine, you can't mitigate. But to take someone out of their home for 14 days to isolate or quarantine without the social supports necessary to put food on the table, to look at what benefits were available, caused people not to come forward, caused our contact tracers to have more difficult job trying to find out how we can safeguard everyone in the community. So we embedded, Department of Health embedded in every single one of our counties, social support individuals whose primary responsibility was to work with the contact tracers when the contact tracers perceived that the inability to get more information was because of the fear of having to leave a job, having to be able to put food on the table. So all of our counties have social support individuals, and we have identified in every county appropriate isolation and quarantine bed spaces so that individuals have a safe place to isolate, but also the support that they or their families may need. It's not perfect. We call upon so many individuals and organizations to help us with this, including the Y, the health hubs. We can't do this alone from the department. So it really has been a community of individuals to support the vulnerable population. And lastly, what do we have to do going forward? I think we have to realize that particularly the infrastructure of community public health has been decimated over the years. We have built that up. We started with 300 contact tracers. At the beginning of this pandemic, we now have over 3,000 embedded in local health departments. We cannot go backwards. We have to make sure that the community public health infrastructure is there to support people where they live.
Thank you, Commissioner. You raised such salient points, and there's just a few things I'd like to react to as we pivot into the next question. I love how you frame this sense of unmasking, right? So as a health equity doctor and working here at University Hospital in Newark, where we've centered on a Black and Brown community, or centered our work on a Black and Brown community. What we're also finding that's a part of the equity conversation is at the peak of the surge in the spring, not only were people suffering from coronavirus, but they were suffering from this paralyzing fear, right? Not reporting to the hospital when they were sick, not reporting even through telehealth to their physicians when they were sick. And it forced us to think about how do we communicate with communities of color? How do we communicate with historically excluded groups? How do we communicate with disenfranchised communities in ways that says, I acknowledge, I validate, I hear your concerns, and this is how our response will be adaptive to what your particular needs are. And I think what you're describing is how the state with a health equity lens has been forced to become adaptive. And so I would say to you, Dr. Besser, just thinking more nationally, keeping health equity at the center of the conversation, what do you think we need to do differently in our rebuild, right? We're talking about that third pandemic, that economic devastation. What do we do differently in our rebuild, as well as our sense of replenishing health and mitigating the debilitating effects of the pandemic?
Wow. Dr. Chris, when you think about the rebuild and you think about equity and principles of equity, it's hard not to get to issues of economic exclusion because there's so much behind the disparate impact of this pandemic that has to do with economics. What I am desperately afraid of right now is that within a matter of weeks, the remaining federal protections and supports that people have are going away. And so there are tens of millions of people in America who will be at risk of eviction. There are millions of people who will be losing their homes. There are millions of people who will have lost their unemployment benefits and will have lost access to sick leave and family medical leave. And Congress is doing nothing. Congress is doing nothing. And, you know, when I look to what our state is doing and our state's centering of principles of equity around this response, it's absolutely clear that the state cannot do this without federal support. You know, states can't run deficits the way the federal government does. And so looking at the tough decisions that our state will have to make, you know, if you have to balance the budget, you're going to have to be deciding about, okay, do we make cuts in education, or do we make cuts in housing? Do we make cuts in jobs? Do we make cuts in health services? And that shouldn't be. As we look to rebuild, I'm hoping that the next administration is looking to build a more inclusive economy, so that you know, when you look at right now, the biggest growth sectors in the economy are on the side of business are small businesses that are run by women, and in particular women of color. And you know, those are also the businesses that are taking a hit. So when we're looking at rebuilding going forward, and we're looking at maybe payroll protection coming again, the resources have to be targeted at intentionally at the sectors that are getting hit the hardest. Or what we're going to see is similar to what happened in New Jersey after the big downturn in the mid-2000s, is that those parts of our economy will be the longest to recover. And that would just be devastating, given how much energy there is in those sectors for community growth.
Thank you both for those responses. And we'll continue to talk about equity all throughout today, right? All throughout this town hall, all throughout the sessions that are to follow. And because health equity matters. And I think we are at a point in our nation, or point even in our state, in our regional areas, in our locales, that we can't put our head in the sand. We have to center and focus on those determinants, those social determinants, those structural determinants, those non-medical or non-clinical determinants that really go into life exposures, into creating opportunities for health and for wealth. So I want to turn our attention to what's very timely, Commissioner. Yesterday, the Vaccine Advisory Panel recommended that the Pfizer vaccine be approved through emergency use authorization. And I know the state of New Jersey has been very busy, very focused on planning how we would be able to distribute allotments of vaccines. What do you think is the most important next step for the state to take as part of its distribution and planning?
Thanks for that question. As you can imagine, we've been working nonstop on developing a vaccine distribution plan that is fair to everybody and open access to everyone. Just to, again, level set where we are, the 1A category, which is required for the first vaccines, includes healthcare workers. In New Jersey, healthcare workers, paid and unpaid healthcare workers who are at risk of coming in contact with infectious material, whether they're in the facility or in the community, measure 650,000. 650,000, and as you know, many of those healthcare workers are from communities of color, and many of them are women, and many of them are single parents. Then you go on to long-term care, which is a highly vulnerable group. There's 70,000 residents in our home care, our long-term care facilities. And again, another 100,000 employees, primarily certified nurse aides, taking care of those residents. So that's 170,000. They will be vaccinated first, as required under the EUA and the CDC guidelines. But I want to move on to what we call category 1B, the essential workers, food service workers, transportation, all of the individuals Dr. Besser shared that cannot work from home and that are public facing. In New Jersey, that number is almost 3 million people. We have 9 million people in New Jersey. 3 million of them are in that essential category. Public facing, cannot work from home, at high risk and vulnerable. We are a service economy in New Jersey. So our challenge from the department is, how do we open up enough vaccine sites, safe, secure sites, to provide access, not only to the healthcare workers, we will take care of them, not only to long-term care, the federal partnership program with the pharmacies will take care of that. Our concern are there 3 million essential workers, and making sure that when we get adequate doses, that they are immediately within 24 hours given to individuals who need it the most. So we plan on setting up 6 mega sites that will be able to do, 2,000 doses a day. We plan to, and we have enrolled all of our FQHCs, our local health departments, our links agencies, all of our hospitals, all chain pharmacies, urgent care centers. We expect by January, February to have over 300, probably 500 vaccine sites throughout New Jersey, and mobile sites going into communities, along with a core of, we're calling them COVID-19 educators and vaccine ambassadors from the communities, going door to door to teach about vaccine, because vaccine hesitancy and public confidence is we believe one of our biggest hurdles. But going door to door in vulnerable populations, teaching, encouraging, and then also making sure that people come back for their second dose. The regimen of a 2-dose, which is Pfizer and Moderna, it really gives us some logistical issues. And you all know, historically, 30% of people don't show up for their appointments or never show up for their follow-up appointments. That number has not changed over years. And we want to make sure we get that 30%. So a lot of planning. We're ready to go. We do expect some Tuesday or Wednesday of this week to be very important days for New Jersey. And through December and early January, we'll get the healthcare workers. And we will be planning very aggressively to bring up the mega sites. So everyone will have a place to go to get vaccinated.
And I can second that. We are likewise looking through the logistics and the potential distribution schemes here at University Hospital, an eager partner with the state to disperse these first allotments of vaccines, a lot of going into that. But Dr. Besser, that points me to something that the commissioner just talked about. So we can do all the planning. We can interrogate our distribution schemes and things of that nature, but what do we do about hesitancy? What do we do about the skepticism that's there? And it's even in healthcare workers. We've surveyed our workers here about those who felt they were likely to get the vaccine, those who were unsure about whether or not they would get the vaccine, and those who were saying, right now, I'm not going to get the vaccine. And I have these conversations frequently in community, via text, via phone, or virtual formats. What do you say we need to be considerate of in that dialogue with community and healthcare workers as well, to ease those concerns so that when vaccine is available, people are willing to take it?
And Dr. Chris, that's a critical issue. To have a safe and effective vaccine, but not have people want to get it is really it's almost mind blowing because you see the path to this pandemic ending, but it's going to take people believing that this vaccine is safe and effective. I'm a general pediatrician, and I remember early in my practice, I was practicing out in San Diego, and I was, I know as a general pediatrician that there's nothing I do in my practice that has more value, proven value to the kids I take care of than getting them vaccinated fully and completely and on time. And I remember talking to some parents who were shopping for pediatricians, and they said, we want to come to your practice, but we don't want to vaccinate our child. We have real concerns about that. And I said, I think you need to find a different pediatrician. And I felt really good about myself. But then, over time I thought about, well, that doesn't do anybody any good. And I changed my approach. And in the future, if someone said they didn't want to vaccinate, I said, I'll work with you. And what I found was, over time, developing a relationship of trust and listening and really trying to understand what the concerns were. A lot of the parents who came in feeling that way over time got their kids vaccinated. And I think that if the approach here is that we have to ram this vaccine down into people's arms, we're not going to get there. We have to listen. We have to be respectful. We have to provide resources to people in communities who are trusted. And in different communities, that will be different voices. And so in some communities, it will be faith leaders and local practitioners and community organizers. And, if you think about the recent election and how a lot of people came out to vote, it was through contacts from family and friends. And so helping to get that going so that you get this buzz where someone who's been vaccinated can share the experience with a friend or a relative. And yeah, my arm hurt and I felt terrible the next day, but you know what? Now I feel like I'm protected, and I'm doing this not just for me, but I'm doing it for my grandmother. I'm doing it for people in my community, for people who are at great risk. It has to be done with respect. It's going to take resources, and a lot of states don't have the dollars, and the federal government has to put that out there. But if the thinking is it's going to get done by just putting out public service announcements from Washington, it's not going to get there, because you're dealing with a lot of communities that have a legacy and a history of mistreatment, of medical experimentation. And that's not going to be overcome by the same authority figures or figures who represent the same institutions that caused harm for hundreds of years. It has to be done by recognizing and listening. And what I'm optimistic that, while the surveys now are showing significant numbers of people who are hesitant, that as it rolls out, if there's transparency, when people are having problems, there's a sharing of what happened and an understanding, like the incident recently out of the UK, where there were people who have a history of severe allergic reactions. What they found was that people with severe allergic reactions, at least 2 people, had a severe reaction to this vaccine. Well, in the trials, they didn't include people with serious allergic conditions. And so it's something that's learning that will change how practice is done going forward. If that's done in a way that's open and transparent, it won't lead to further hesitancy. It will lead to faith in the system, that people are looking, they're listening, they're learning. And some people who are hesitant today may feel over time, that as they see people get protected and people who are able to then do more things that they otherwise couldn't do, that people will come around and want to get the vaccine. But it needs to be a slow, extremely respectful process.
I couldn't agree with you more. I've been sharing and expressing this as we have to walk hand in hand together on this journey with people. And we're doing that right here at University Hospital, through virtual town halls, through rounding on our units, asking the questions. I just expressed how I've been doing that in community, literally through text. Someone reached out to me, a local community leader here in Newark, New Jersey, and says, as a Black woman, I have a sense of pause. Do I recommend for people to take the vaccine? And I've been saying, and I will say this loudly, we must center the conversation on what the fears and the concerns are so we can begin to unpack them. I volunteered for the Moderna-sponsored coronavirus vaccine trial. And I did that because it was a way to live my father's legacy forward. My father was a research scientist, and he would frequently tell me, follow the data, follow the science. And seeing how so many of our patients here in Newark and more broadly have been devastated, I wanted to be a part of the solution. And I think as folks like myself, our CEO, Dr. Elnahal, others across the organization participated in that. We're able to share our stories, able to share our narratives. It's going to be so important because frequently I hear in Black and Brown communities, what about Tuskegee? What about Henrietta Lacks? What about enslaved Black women who endured barbaric gynecological procedures at the hands of Dr. Sims? And what about the ongoing disparities? And I say, as we have those transparent and informed conversations with empathy. I validate, I hear, I know your concern. We can guide people along this journey and get to where we need to be to have the levels of protection and immunity because we've been able to vaccinate the majority of the society. It will be a work in progress. I just want to manage everyone's expectation around that. And I know the commissioner, your sleeves are rolled up and they never have been rolled down. And the state is really invigorated around this. And so being able to partner with those trusted messengers are going to be so important. I want to use this as an opportunity to think about even more local lens and to ask both of you, are there local stories across New Jersey that you're aware of that you could share today, lessons that we've learned across this response during this pandemic that can inform and inspire other municipalities, other regions to say, this is how to show success, to demonstrate effectiveness in tackling the pandemic?
Yeah, I'd be happy to share. I mean, we have so many stories. I'd be happy to share a few of them. Let's go back in the beginning. We came to work one day and we got a phone call from a CMO from one of our hospitals. He said, I'm experiencing something really unusual. A fella came in and he's in intensive care and not doing well. And the family told me that there's a number of people within the family that don't feel well. And his brother is actually in a Philadelphia hospital in the same condition. This was before March 4th. And it turned out that an individual in the family had been exposed and had COVID-19. They had a family gathering of 25 individuals. At the end of the day, 15 of those individuals became positive for COVID and 5 individuals expired. That was very telling to us very early on that we were dealing with something that we had never seen before. But it also gave us a great lesson about how valuable the connectivity to our local communities and our hospitals are. We would not have known about that if that CMO did not feel comfortable picking up the phone and saying, hey, I'm seeing something that's really very different. So what we have now is open communication, and we are hearing stories every day about our local health departments and how they're collaborating with medical schools and schools of nursing to bring testing into the homes, to experiment and be innovative about when we first brought out saliva testing, working with Rutgers and making sure that everybody in Burlington County got tested. Burlington County has been far ahead of a lot of other counties in really connecting with their communities. We saw the same in Westfield. The health department in Westfield received a grant to specifically impact vulnerable populations and increase testing, and very innovative and out there on the streets. And Dr. Besser said something that we have talked about here at the department, which I think is so important, the concepts of community organizing. That is going to be the key to building public confidence. It's not going to come from my office, definitely not going to come from the federal government, but community organizing, using those concepts to bring people together. We had the outbreak in Lakewood when the rest of the state were seeing positivity rates under 5%. Lakewood, after religious holidays, shot up to 28%. The governor, myself, the religious leaders, we went down to Lakewood, we had a meeting. We said, we need your help. This is what we need to do. We need to get as many people tested as possible. We need to open up more bed spaces. There's multi-generational housing here. We need to be able to separate people. We got such collaboration within 6 weeks, the 28% went down to a little over 10%. And it showed how together, a community that organizes itself, the local health department, the religious leaders, the community leaders, organize themselves to make a real difference. That's one of my favorite stories because I think it is so illustrative of what we have to do in community over community over community. Community organizing. I think that is going to be the key to overcome the vaccine hesitancy that is rooted in real fears because of past experiences and past history. It's going to be community organizing.
Yeah, I just want to elevate two words that you said for all of us to really reflect on those and to take those forward with us: community organizing and collaboration, right? Community organizing and collaboration are so key in underpinning not only our response to this pandemic, but how we go about to build environments that encourage, shape opportunities for health. Dr. Camara Jones is such a mentor for me in the field of public health. And the way that she defines racism, she talks about racism as a system of structuring opportunity, where one group based on phenotype and a social construct is disadvantaged, and another group based on phenotype and a social construct is advantaged, but the strength of the society as a whole is sapped. And I think it's going to be so important for us to come out of this, a story that I hope it is emerging. I believe it's emerging in places like Newark and other places across the state, is that how we can collaborate to look at the most disenfranchised and how we can collaborate to uplift hyper-local resources in order to solve the gaps. And I think that's just going to be imperative for our public health response going forward. Dr. Besser, if we could just navigate a little bit and do a bit of a pulse check for us and say what policies are needed in the short term versus the long term to help bring us successfully out of this pandemic.
Thanks, Dr. Chris. When you mentioned Dr. Camara Jones, I had to smile because I was at CDC when she was there, and her metaphor for structural racism and the growth of plants just made it clear to me in a way that it's like, oh, okay, I get that. So when I think about policies and what's needed, I think the way you break it down in terms of the short term and the long term is critically important. In the short term, if we believe in equity, and by that, everyone having a fair and just opportunity for health and well-being, we need to ensure that people have the supports to be able to follow the guidance of public health. Commissioner Persicelli was laying it out. People don't want to say who they had contact with, because if you tell who you had contact with, for some of those people, it's going to mean they're going to lose their job. If you look at the majority of lower paid workers in America, they don't have sick leave, they don't have family medical leave, and being asked to stay home for 2 weeks is not going to get the job done. So we need the federal government to step up. We need them to put money in people's pockets. That worked back when the CARES Act was there in the spring, not just in terms of people being able to pay off some of their bills, but it stimulated the economy. You're looking at people who need to spend money to provide for their needs, and that's a good thing for the entire nation. So putting money in people's pockets, expanding unemployment insurance, providing guaranteed sick leave, family medical leave, those are important. We have to put back in place not just eviction protection, but rent support, because the bills that were passed back in the spring that provided eviction protection, meaning, okay, you can't be evicted, but your rent's accruing. So for many people, they now have 9 months of rent to pay, which is a non-starter. Same thing when it comes to mortgage protection and utility shutoff protection. These things have to be put in place. These are some of the short-term things. Forbearance on loans is another piece of that expires the end of December in terms of student loans. We need to see the payroll protection plan put back in place and refinanced, and we need to ensure that the resources in that are going to the people who most need that money. We know that there was a lot of challenges with that program, with money going to larger businesses that really didn't need those resources. So that's short term. In terms of long term, when you look at countries that have been the most successful at combating the pandemic, there's the social support, the social safety net is quite different. We're the only wealthy nation that doesn't provide universal health care. And that's just unbelievable. There are many paths to get there, but everyone in this country should have access to high quality, comprehensive, affordable healthcare. I remember when CDC first put out their guidance in terms of what you do if you think you have COVID. They said, don't go to the hospital, unless you're gravely ill, because that could either expose you or healthcare workers, and you may not need to go. Call your doctor. Well, 28 million people at the start of this pandemic didn't have a doctor. So what are you saying to those people? A lot of states put in place drive-through testing facilities, and you needed to have a doctor's prescription. Well, if you didn't have a doctor, you didn't have the prescription. If you didn't have a car, you weren't going to get to the drive-through. So those are some of the things that have to be addressed. Universal healthcare has to be a big part of this. We have to look at housing and the critical importance of housing. And we have to look at what truly is a living wage and ensure that everyone in America has a living wage, has sick leave, has family medical leave. These are just basics. These are fundamental things that, if they were in place, would help to ensure that everyone had the opportunity to protect their health, the health of their families and their communities. But beyond that, we have to look at these factors we've been talking about around structural racism. Why is it that people have the inability to move to opportunity in America? What is the legacy of redlining? I'm a volunteer pediatrician at the Henry J. Austin Center in Trenton. And the life expectancy for a child who's born there is 74 years. 74 years. I live 14 miles from there in Princeton, New Jersey. The life expectancy for a child born here is 87 years. Well, why is that? It boils down to structural racism. And I said, well, why don't the families from Trenton just move to Princeton? Right? I mean, people chuckle about that, but we have to look to see what are the barriers for people to move to opportunity, and why is there such a difference in opportunity across our cities and our communities.
Thank you for that response. I'll just say one thing, because it just leapt into my mind. Dr. Jones would also say, if you don't ask the question, how is racism operating here, you won't be able to provide the answers and the solutions, right? And so I think what both of you have been describing are these very incisive, very critical processes that need to be reflective of the myriad factors and barriers that are present at every level. And I know actually what it's like to be uninsured. I have a chronic health condition, and at one point my training was interrupted. And had it not been for family, I would have been someone who had that economic vulnerability. But I can tell you, when I was uninsured, it changed my health-seeking behavior. Yeah. I suffered a concussion. I fell off of a stage, unfortunately. And I said, please don't take me to the hospital. I was a physician. And so those are real world, real life scenarios that we have people grappling with, even in the midst of a pandemic. So having those informed policy conversations are so very necessary. Just really quickly, just want to wrap up with what gives you hope. Commissioner, what gives you hope?
I've been working a long time, so I have a lot of experiences. What I've experienced in this past year, and I'll say a year almost, we started looking at this in January with the Wuhan situation. What I've experienced this past year, and the ability of people to step forward to do the right thing, particularly from the governor all the way to community volunteers, to step up and do the right thing, and to collaborate and to help and to want to help one another. I have hope that we will not only come out of this pandemic, we will come out socially stronger. I really do believe we're setting the foundation to start chipping away at all of the ills that have gone on for a century. And it truly is that long. And I believe if we waste that opportunity, shame on us. People want to do good. They want to help their neighbor. That is what I have learned. And that gives me hope.
Dr. Besser, what gives you hope?
I would say, very similarly, the conversations we're having now are fundamentally different from the conversations of a year ago, 2 years ago. And that gives me hope. Instead of the focus being on individual behavior and fixing or changing the individual, we're having so many more conversations about structures and systems. And that's so important. As you were saying before, we live in a society in which, for some people, health is the easy choice. There is privilege, there are opportunities that people are not even aware of because it's just given as the norm. And for other people, there's a barrier at every turn. And we're talking about those barriers, those barriers due to racism and sexism and classism. These are things that are so fundamentally important. And we're seeing a change in the administration in Washington, and with that comes an opportunity to look at new policy solutions. And I truly believe it's going to take changes in policies. It's going to take changes in mindsets of how we think about health and what it takes to be healthy, who we value in our society. And it's going to take providing support to groups at the community level. It's community power that's going to get this done. It's not going to be a top-down solution. And so I see all of these things coalescing right now. And I'm very optimistic that we will see change.
Thank you for that. You both have fed my soul in this conversation, and hopefully everyone else who's been a partaker, you can likewise say the same. I'm going to pass the baton to Darren Anderson to lead us into Q&A with the audience.
Dr. Chris, thank you so much for your moderation. And I tell you what gives me hope, and I will echo the comments of Jen Velez, that we have 3 dynamic healthcare and population health leaders here in the state. You operate within integrity and transparency. And because of that, we are very lucky to have you here in New Jersey. We have a litany of questions here. And as I'm kind of cycling through the number of questions, one of them that has arisen is one of the comments that the commissioner had made. She said that here in New Jersey, there's 3 million essential workers out of a population of 9 million. One of the questions that we received is, are teachers and childcare workers a part of that number? Because we are a service economy, how do they fit in the plan with the vaccine distribution? And
thanks for that. Thanks for that question. I want to draw everyone to the CISA definitions of essential workers, and you will find health and safety, service, governmental workers, bankers. I mean, there's a whole list, and teachers are definitely in there. Now that we're on the cusp of starting to vaccinate, I can tell you that I am getting multiples of emails every day saying, I think I'm an essential worker and I should be higher than other essential workers. I want to assure everyone, there will be, by April, May, enough vaccine to meet the demand. So this is not a scarce resource that you'll never see again. We will make sure that the essential workers in New Jersey get vaccinated. And our goal here is to vaccinate 70% of the adult population in New Jersey in 6 months. And our objective is never to leave a dose on the shelf. So we will vaccinate you, and we will get to all 3 million essential workers. We just want you to stand up and get in line.
Thank you for that. Dr. Besser and Dr. Chris, we are promoting you as a panelist now because you are a litany of information.
Yeah, I'd like to add. I'm really inspired by the work that Commissioner Persichilli and the New Jersey State Health Department are doing. It's critically important. Her point, though, in terms of the timeline, April, May, makes it so absolutely essential that we don't take this moment where vaccine is starting to roll, that gives us such hope, and say, great, we don't have to do all of these things that we don't want to do anymore. That's not the case. Vaccine is not going to change the trajectory of this pandemic this winter. Yes, it's going to help those people who get the vaccine. But if we take our eye off of what really needs to be happening right now. And that's wearing masks, social distancing, hand washing. If we stop doing those things, we are not going to see a change in the number of people in New Jersey who get infected and who die. If we have social gatherings on the sly and say, well, those rules don't apply to me, we're going to see this continue to spread throughout our state. So we have to continue to do that while we're vaccinating. And I worry that people are just so overjoyed about the fact that vaccine is on the way that they say, finally, we don't have to do these things anymore. And that's that causes me to lose some sleep.
I always say the word vigilance, and I will keep saying the word vigilance. I think we need to stay vigilant as households, vigilant as communities, as organizations. And I can say we're doing that here at University Hospital, understanding the myriad factors, which are so complex, that actually got us to this point, keeping a pulse of that so we can get us out of this point. And like Dr. Besser said, there is no silver bullet. And I keep saying that too. And I want people to understand, I spent days before Thanksgiving on the phone, encouraging people, please don't mix households. And so I just want us to continue to have that local and national conversation about how we best keep ourselves safe, and how we best interrogate systems and tear down those systems that enable inequity and build up those systems that enable equity.
Excellent. And I think we have time for one more question. We received a question from someone that works with the state's children's systems of care. The question is, where can families find support for isolation? And I'm going to throw in quarantine there as well. How can we better support these families of color, families that live in vulnerable communities and marginalized communities?
Yeah, call your local health department, or in your local links agencies. They have the connectivity to the social support individuals that are available in every county. And you should connect with the social support individuals, because they have a full listing of all of the services that are right now available to individuals who either need to be tested or isolating or anything related to COVID-19. So please reach out. We've redeployed individuals locally for just those purposes.
Definitely, and I'll just add, from our perspective as an anchor institution in a community here at University Hospital, this is something we've had our pulse on, not just for our workers back in the spring when we were at the height of the surge then, and thinking about places where our workers could safely quarantine or isolate in the partnerships that were surfacing and coming to light, but also in community. As you said, Commissioner, working with the local health departments, working with your municipalities to say, what are those community resource guides? So we were doing pop-ups in different neighborhoods throughout the Essex County and more broadly, where we could not only provide health screenings, but we could provide SDOH, social determinants of health screen as well, to be able to understand what needs are there so that we could then link and connect people to known assets and resources in community. And that's just going to be important, not just for this pandemic, but that's important for how you build healthier communities going forward.
And Dr. Besser will give you the last word here for the second.
Yeah, I don't have anything to add on that, but I think the spirit of the question is the right one. Everyone has different needs, and so it's not one size fits all. And it's critically important that you connect locally so that individual needs are met. I worry greatly that people who are exposed, who are coming back to households where individuals may be at greater risk, have more challenges in this. And if it's about losing a job by being removed from your household and not being able to go to work, we have to address that so that people can be protected.
Excellent. Well, once again, we have to thank you, Dr. Besser, Dr. Chris, and Commissioner, for being here with us today. We've received a number of questions, and unfortunately, we cannot get to all those questions. But all of our panelists have agreed to helping us to answer those questions, and we will be communicating those answers post-conference. So once again, thank you very much for your time. Thank you for your leadership. Thank you for your transparency. Thank you for your integrity. And thank you for leading the way as we come together as a community in unity to make sure that we can defeat COVID and that we can support our communities.
Thank you.
Thank you.
Thank you.
Thank you very much.
We will begin our transition into our second hour. We have a dynamic panel here for you as we begin to take a deeper dive into the social determinants of health. We have as our moderator, we have Natasha Rosario. Natasha currently serves as a director of opioid response and policy at the New Jersey Department of Health. Prior to joining the department, she was named to serve on New Jersey Governor Murphy's healthcare transition team. She also served as Senior Director of External Affairs at the Camden Coalition of Healthcare Providers, an organization committed to advancing the health and well-being of individuals with complex health and social needs. She received her BA from Columbia University, MPH from Johns Hopkins, and have a Juris Doctor from American University. So once again, we're going to transition into our panel of experts, and I will pass the baton over to our colleague, Natasha. Natasha.
Thank you so much for that. And it is such an honor to be with you all and to be with our panelists today. I am feeling so hopeful. And that last panel, I was looking at the comments in the chats, and I think it certainly replenished my soul. And so it's just, I think it's such a privilege, and it's just so necessary that we're taking time to pause. This has been such a rich year, and there are so many lessons for us to take forward as we build stronger communities as well. So this panel is focused on the social determinants of health. Excited, humbled to delve into this large discussion with some of my fellow panelists. So Kathleen Noonan is the CEO of the Camden Coalition of Healthcare Providers. Martin Lawson is the Executive Director of CUMAC, an anti-hunger organization in Passaic County. And Ritha Onitri, who is the Director of Community Engagement at the New Jersey Institute for Social Justice. They all have amazing careers and wonderful bios. So I encourage you to look at the conference materials to look into that. Just very honored to be with these folks who are change agents and leaders, and just a note of gratitude. Just thank you so much. Thank you so much for all of the work that you're doing. I think the last session just really touched on the importance of partnerships and working together, and we're doing this hand in hand. And so just having the privilege to work with a lot of organizations across the state and seeing what all of you do in terms of addressing substance use disorder, homelessness, economic insecurity, food insecurity, social and racial justice and incarceration. I mean, these are all of what we're talking about when we're talking about the social determinants of health. The social determinants of health, I mean, just to take a moment to pause, I think a lot of folks who join this conversation probably have an awareness, but so we're all on the same page. It's really powerful when we think about what those things mean. It's the conditions in which we were born, we grow, we play, we work, we live, we age. Just take a moment to think about all of those conditions and how they have fundamentally transformed at a personal level, at a collective level. There's a lot here. And I think when we're talking about the social determinants of health, what's really at the heart of it is a conversation about equity. And that's been the through line throughout all of this, right? It's an idea of equity. And I think yesterday was World Human Rights Day. So I think it's worth acknowledging that as well. And that's really about human dignity, which is also a very powerful word here. It is human dignity. And I think what is incumbent upon having a conversation about health equity is that we take time to pause and look here, look inward, and think, what more can I be doing? what biases are swimming here. We all have them. What more can I be doing? Where are my blind spots? What more can we be doing? I think Dr. Besser spoke about, all of the panelists spoke about building something better and more robust. So what more can we be doing in that space? We have to not only shift here, we have to shift our policies. We have to shift a lot of things in the systemic space as well. And so I think this is going to be a really large discussion, and working with all of you and talking with all of you who are really on the front lines of all of this work right now. Before we delve in, just because I am an employee of the Department of Health, I just have a couple of public health announcements. So one, vaccines are really important. If you haven't gotten your flu shot, it's not too late. Two, science is also really important, and it's really important. I'm sure we all are getting our news from credible sources, but take it in and spread it. Share it with your family members. I will speak from personal experience. Sometimes that's harder than other times, but share it with your family members, share it with your communities as well. Be ambassadors of science, be fans of science. And then, as our beloved health commissioner says at all of her pressers, the 3 W's of good COVID response: wear a mask, wash your hands, and watch your distance. And it's not glamorous, it's not attractive sometimes, although there are some very fashionable masks out there, but it works. And so in just prepping for this conversation, I was taking a minute to pause to think about what vantage point I could bring from the role that I'm afforded at the department. And I'm just so humbled to serve as the director of opioid response and policy at the department. And I think earlier we heard about this myriad of different pandemics and epidemics coming together, right? And my gosh, looking at, every morning I'm looking at COVID trend lines and overdose trend lines. And it is challenging and it is humbling. And I think at this moment, right, I think there's a lot of concern around just an uptick in overdose deaths. You have the constellations of grief, isolation. A lot of folks have lost their jobs. Housing instability. There's just a huge nexus to create an uptick in overdose deaths. And in May was extremely sobering because we saw the highest number of overdose deaths in the state, not just for 2020, but for 2019 and 2018. What's been interesting is that overall there's been a downward trend in overdose numbers. That said, when I say that, and I know all the epidemiologists on my team are going to say, please don't say anything more because the year is not over yet and the holiday seasons are upon us. Holidays are hard. Holidays are hard. So I think just with that, it gives me just a lot of understanding and it underscores the importance of the social determinants of health. Now, in addition to that role, like so many of my other amazing colleagues at the Department of Health and other departments, we've all been rolling up our sleeves. I don't think anybody's wearing their sleeves down at this point. Everybody's sleeves are rolled up and have been helping just with COVID mitigation strategies for vulnerable populations. And I think this vantage point of just seeing all of this come together and play out, I will say that taking a social determinants health equity approach, it's hard. It's not for the faint of heart. When you think about centuries of structural racism, poverty, grief, social isolation, all of these factors coming together, there are no easy fixes. My gosh, I wish there were, but there are no easy fixes. I will also say what is also part of this is that a social determinants health equity approach is the only way that we can really move forward. And it really holds the possibilities for solutions that are concrete and sustainable for all racial, ethnic, and social groups so that they can really attain their highest standard of well-being and health. And that's just really important. So when we look at social determinants of health, and we look at all of the perils involved and all of the promise, what it also highlights is that it is a really powerful framework, and it evokes our moral imagination to really bear witness with tremendous humility all the fault lines, the cracks in our system, and also gives us courage to dream of something better, right? What do we want our world to look like? What do we want our communities to look like? And so as part of embracing that approach, the Department of Health has embarked upon the Community Conversations Project, which is with the New Jersey YMCA State Alliance and Healthy New Jersey 2030. And it really is a way of memorializing all of these stories, the hurt, the pain, the resilience, the pandemic in all of its complexity through social media campaigns, creative artwork, poetry, what various forms of expression. And it's really to help us to build empathy and healing, which is so necessary right now, and to help us move forward to implement these effective policies and to build more resilient communities. So in the spirit of that conversation, Community Conversations, which is shifting the light onto this mosaic of stories, I'm going to shift the light to my panelists who embark upon this work with tremendous grit and a moral imagination and social courage. And so I'm going to begin with you, Rita, to tell us a little bit more about what your organization does and just to introduce yourself a little bit more.
Sure. So thank you so much for those remarks, and good morning, everyone. The New Jersey Institute for Social Justice is a policy, and you could move to the next slide, please. So the New Jersey Institute for Social Justice is a policy advocacy organization that directly addresses issues in the area of economic justice, criminal and youth justice reform, and democracy. We engage community residents from the ground up to create policies that will impact them directly. You can move to the next slide. As part of my responsibility, I lead the 150 Years is Enough campaign, which seeks to transform New Jersey's youth justice system by closing our youth prisons, which are old, far away, and costly. Most importantly, we work to redirect funds from incarceration to community alternatives. And let me point out that incarceration has been identified as a very important social determinant of health. Nationally, between 65 and 70% of the 2 million children arrested each year have a mental health diagnosis. In addition, incarceration is a serious racial justice issue. Today, a Black child is 21 times more likely to be locked up in our state than a white child is, even though research shows that Black and white children commit most offenses at similar rates. And this is actually the highest disparity rate in the nation. So this troubling data moved us to launch our campaign on June 28th, 2017. And for the sake of time, what I'm going to do is just move to the bottom of the slide, which captures the work that the campaign has been doing in response to COVID-19. So if you can click once, and I think it's gonna pull up more information. And if you can click, there you go, thank you. So as the result of our advocacy in April, New Jersey became the first state in the nation to agree to test incarcerated youth, adults, and staff on a regular basis. And so when we noticed that the positive test results started to increase sharply, we actually joined adult advocates and push for the Public Health Emergency Credits Bill. And let me just tell you right now, if you look at the stats, since the COVID-19 pandemic started, 53 incarcerated youth and 111 staff members have actually tested positive for COVID-19. And unfortunately, on the adult side, 76 adults have actually died from COVID-19. That's actually the highest in the nation. And so the Public Health Emergency Credits Bill was actually very important because it was designed to remove young folks out of incarceration, out of harm's way. It provides for the early release of incarcerated adults and youth who are due to be released in the next 8 months. So Governor Murphy actually signed the bill on October 19th, and on November 4th, 50 youth and approximately 3,000 adults were eligible to be released. Now, in anticipation of youth returning to their communities, the Institute partnered with Salvation and Social Justice, and we created a youth justice toolkit. And that toolkit actually has been turned into legislation. So we actually partnered with Assemblywoman Reynolds Jackson and introduced the Restorative Justice and Communities Bill, which provides funding for a 2-year program which enhances, that provides reentry wraparound services and restorative justice hubs. And just, what you see here is our first community engagement initiative in which we mobilize folks, and you see young and old, to actually fight for young people and to really put forth the notion that there are no throwaway kids. So with that, I'm going to turn it over to the next speaker. Thank you so much.
Thank you so much, Rita. I love that picture. Speaking of hope. Kathleen, I'm going to turn to you to introduce the Connecting Coalition and some of the work that you're doing amidst the pandemic.
Great. Hi, everyone. Good morning. It's so great to be part of this panel and part of this program. We were asked to tell you a little bit about what we've been doing on COVID. And so if you could move me to the next slide. I thought the best way to start with that is to just show you who we listen to a lot when we respond to COVID. This is an excerpt from a podcast, for the former reporter of Market Report, the senior reporter who spoke with one of our clients in April. And let me just say 2 major takeaways from this excerpt. One, this is not an issue about education. The communities that we're talking about know very much the risks that they are dealing with. And second, this is about exposure to risk and then the inequities that have created different and greater exposure for our communities of color, and also the inequities that have created different risks around health for our communities of color. So Suzanne, if you can just play the tape.
Antonio was as sober and stable as he had been in decades, but the fear of getting the coronavirus had him thinking of turning back to his old comfort, heroin. It was an ugly choice and it didn't sit right. Friday night, the pacing started. Antonio turning over his choices, his anxiety ratcheting up.
It got worse and worse and worse. The anxiety got really bad. I couldn't sit down for 5 seconds without my body just reacting. And I would just walk around the apartment back and forth and talking to myself. And then after a while, it got so bad that the anxiety started making me throw up. I was in bad shape.
He got so twisted in his thoughts and fears, Antonio barely slept. By Sunday, he needed some help.
At first, I was embarrassed and felt like I was weak. But after about 2 days, I started reaching out to people because I was like, I got to tell somebody what I'm going through.
Antonio called friends from his support group, a group that for the past month has been forced to hold weekly conference calls instead of in-person meetings. And of course, he called Brian.
When shit goes to shit, He's usually what I call. You know what I'm saying? If it's not something major, I'll figure it out. But
Thank you. So Suzanne, you can move me to the next slide.
Antonio was as sober and stable as he had been.
Maybe you can shut that. There you go. Great. So Brian is one of our phenomenal community health workers. And Antonio was trying to figure out how to go get his MAT, which he really needed. And he needed to get on the bus to do that. So what have we been doing related to COVID? We've been listening to the community and bringing their ideas, sometimes jointly, to decision makers. And I'll just give you a quick summary. Bringing the ideas of test sites for walkers and people who rely on public transportation. I will tell you that the initial site in Camden that was supposed to be the public site was a site that was not on public transportation. There was no Medicaid transportation set up because it wasn't considered a medical site. And half the people that used it were suburban people that figured out you could go into Camden and get a quick test because people in Camden weren't getting there. We've actually fixed that. We now have pop-up sites, and I'll tell you more about that later for this next round. We're giving masks to our community advisory committee members and having them distribute them. Just walk up to people and give them masks and tell them about them. Those same people now are part of an ambassador program. And I know that the commissioner mentioned that program. Our program pays people because we really think it's very important that this work is not volunteer work. And so we are hoping that the state program will be result in payment as well. But right now we do that. Food banks have to deliver food just like Amazon. One of the things that we were able to do was get some of those Medicaid transportation vans that weren't taking people to the doctors to deliver food, but we need more of that. And finally, talking about permanent housing, there was nothing worse for our care team than having to tell a homeless person that they were free to go from a COVID homeless hotel, a hotel where we actually saw them get better because they were in an isolated space and they just had some time and they had people to talk to them and we had to tell them that their time was up. So that's a little bit about what we're working on and look forward to the question and answer.
Thanks, Kathleen. I think you captured so much of the hurt as well as the possibility, and just I think in the last panel, they talked about adapting and listening. And I think that's how a lot of these solutions have come forward. So thank you. Mark, I'm going to turn to you to talk about CUMAC and some of the work you're doing to fight hunger. So over to you.
Thank you, Natasha. I want to start off by saying thank you to the YMCA State Alliance and to all of my fellow panelists for today. It really is true that to be able to just take a step back and breathe and just take this all in, especially what was said on the first panel, it's a grace even for me right now. And good morning to everybody. So as was mentioned, I'm Mark. I'm the executive director of CUMAC. We are an anti-hunger organization in Paterson, serving Passaic County in northern New Jersey. We're not a food pantry and we're not a food bank. At least we don't see ourselves that way. We use adverse childhood experiences research and asset-based community building principles to define and direct how we deliver our services, which is primarily fresh, healthy food. There are three primary principles that we live by: that ending hunger has nothing to do with giving people food. Secondly, personally for me as the guy driving the bus at CUMAC, one of our dreams is that one day 80% of our staff will be from the community on living wages and full benefits. Currently 78% of our staff is from the community. And as we said, living wages is very hard, but it is our fixed point at CUMAC. And our third principle that drives us and drives me is that the end goal of all of our strategies is to somehow, some way bring a self-healing community or purpose-built community model to our county. Next slide, please. I work next to heroes. My team of 22 for 40 weeks straight. We have not closed. We have not reduced our hours. My team has come in and rocked out for 40 weeks straight. And you can see in their bodies that they're tired, but you can see in their eyes that they're passionate. We went into disaster relief mode on March 9th with two main goals: keep the team safe and intact, don't lay anybody off, pay everybody throughout, and use our capabilities to serve the community. So we have trucks. If the schools needed it, we could move meals for the meal distribution sites. Where else can we supply food to our fellow partners? And these are just some of the stats that we experienced throughout these 40 weeks. You can see that, especially in the first half of the pandemic, it got pretty bad for us. 237% increase in new families serving, burned through our entire food purchase budget by May of 2020. And we're preparing to be in this mode probably through most of 2021 as well. Last slide, please. What I want to share, and then I'll turn it back over to Natasha, is we realized, and I realized in June, we could not stay in disaster relief mode. This work is always about justice and equity, right? At the end of the day, it's always about that. But for some reason, when things get really bad, I'm very hard on my ilk, which is the nonprofit sector. We always default towards downstream reactions to how we can help people. But there's so much more we can do. So in June, I realized we cannot stay in emergency relief mode. So CUMAC will continue to serve, but we've resumed our strategic plans that will eventually culminate in one day a self-healing community model coming to Passaic County through multi-sector partnerships with consensus that is trauma-informed and informed by asset-based community building. So CUMAC will be on the front lines for the rest of this pandemic. But we've got our eye on the prize, which is long-term, upstream, and trauma-informed, because that's what justice and equity is to us. And it's a pleasure to be here.
Thank you so much, Mark. I think so much about this work, and I loved when you were saying it's not about delivering food to people, right? It's so much more, and so much when we're talking. What I heard among all of you is when we're talking about the social determinants of health, what resonates is we're really speaking to what it means to fundamentally be human and honor dignity, right? I think we heard that about this work and why it's so hard to do public health without these social supports. We need that to honor people's dignity in this space. Mark, going to begin with you in terms of questions and just the first round of questions. I can't imagine what your workload and volume has been for all of you, and how you've managed through that, and how you've had to prioritize and make strategic shifts. Mark, for you, in terms of food assistance and the work that you're providing in the community, how have you responded to the increased demand? What kind of shifts did you have to make? What was it like on the ground?
I can tell you that, so on March 9th, when we made the decision that we were going to go into what we call pandemic relief mode, step one, I looked at my director of operations and I told her, we are going to be here for the clients, for our team, and for the community, however needed. We are going to share, we are going to raise money, and we are not going to go away. That was the first thing, was we put a stake in the ground and said, we are going to be here. Our phone started ringing off the hook. We had to pause any program not directly related to emergency relief, repurpose the entire program team to actually answering phones, because to come to us for food, you need an appointment, and we've maintained our appointments even with the increased client load. So you get an appointment and we're going to give you the same kind of food that we want to take home to our families. So repurpose the team, redirect our sourcing, and aggressively go after as much healthy food as we could. The kind of food that we want, that's our standard. If I'm not going to eat it or give it to my wife, I'm not giving it to our clients. So put a stake in the ground, be here, repurpose the programs team, and aggressively go after and secure as much of the food that we need as possible. Those were our first steps to really get to where we needed to be.
Thank you. Kathleen, over to you. I mean, you began your segment, and as you do, shifting your voice and shifting the light to the story that was there. And it was a story of substance use and relapse and mental health. I know the Camden Coalition is doing tremendous, tremendous work in this space. How have you met the immediate need of helping folks out who are at risk for substance use, who are at the risk for relapse? What has the organization done in that space?
Yeah, well, we've done a few things. I mean, first, to Mark's point, we made sure that our staff were okay. This is a parallel play process.
Yeah.
And so I'm heartbroken when I hear about the hospitals who are laying people off, because this is a time when, in my opinion, you go bankrupt if you have to keep your staff supported, and you worry about that later. This is, if there was any a day for a rainy day fund, and we're not organizations on this phone that have rainy day funds, but the fact that bigger organizations, are choosing to lay people off instead of using their rainy day funds, I don't understand. But first, we made sure that our staff knew that we were going to take care of them, that they did not have to worry, that we would do whatever we needed to do, but that the focus was on them being well so that we could take care of other people. That's essential. The second thing is then letting them know that there was not a single thing on their plate, a grant, a deliverable, that could not be put to the side for this issue. And that I would personally call whoever they were working with to say, we can't work on that right now. We, early in March, because we had a couple of people who were sort of worried about this for a lot longer than me, worried about public health issues, we went out to the shelters and got them iPads, so that the shelters had iPads, the shelter staff, and knew how to use them, so that we could be in touch with our clients. And all of our clients, we had them linked up. They knew how to use social media and all that kind of thing. And we immediately moved to social media, to virtual, but also kept up visits where it was really important. And so for some of our things, like our support group that Antonia was talking about, that used to meet in person once a week, they meet every week right now. For our community advisory committee that came together for dinner once a week with a lot of one-off meetings, weekly meetings. We just upped everything to stay in touch and to make sure that people are okay. And we also did that with our own staff. We had a staff call on a weekly basis that was just a support call. So I think all of those things are the kinds of things that we did.
That's great. I know for the Camden Coalition, so much of the lens that you take is around the complex health and social needs. So you're not just looking at substance use disorder, right? You're looking at, here's a person, here's what they need, how do we meet them where they're at? How have you responded on the client side to increases in, I can't imagine, housing and all of that? How have you responded to increased demands with regards to that?
Well, we haven't stopped our program to house people. So we just, the hardest part for us about housing is finding landlords that are willing to take our tenants. So we have not stopped that. We have housed a number of people during the pandemic and continue to do that. We've just set up another program where we are working with an MCO who we think they're going to provide some funding so that we can start stabilizing people in hotels, because we actually saw that having someone stabilized in the hotel during the pandemic was really great. And if we could keep them there for another month or two until we could get them stable housing, they'd be doing much better. And so we have one of our MCOs that is going to give us some funding to actually be able to stabilize people in a hotel while we get an apartment for them online. So those are some of the things.
That's great. Retha, to you, my goodness, I mean, the charge of your organization is addressing so much of the systemic racism that is centuries old, deeply entrenched. When embarking upon a problem as large as that, how do you prioritize? What do you tackle first?
So that's a very good question. So we at the Institute have a very detailed, laid out strategic plan. And we, at the beginning of every year, have some specific goals that we like to meet in each area that we work in economic justice, in criminal and youth justice reform, and in democracy. And so, we are a research and policy organization. So we lay out, what research we want to do, what reports we want to write, what policies we would like to tackle and try to get through. And we're pretty disciplined about making sure that we stick with our strategic plan and that we check it often and that we move toward making sure that we succeed on that strategic plan. And we really try not to go outside of that scope and tackle things that, are not part of either our mission or our strategic plan. We've been very successful about doing that.
That's great. I know that in a lot of what we heard in the previous panel, and a lot of you touched on this as well in your remarks, is to do this work, you need partners, you need collaboration, right? If you're talking about social determinants of health, you're talking about society, and you can't and do it alone. I think on the department side, what I have seen is just particularly just in so many projects, the community partners. Kathleen, we've worked with you and all the regional hubs who've been so helpful in identifying and responding to needs in the community. And so we need that support in that way. I think it's also just so important, and this is a moment of humility as well, is that there is not a lot of trust in a lot of spaces, right? And so even though you may have this solution, you may not be the most trusted person to come with that. So you have to work through these networks and bring that information from that vantage point. I know one of the projects that the commissioner referenced is our persons experiencing homelessness. We're doing a lot of work testing. And I do that with my colleague, Unai Kranzler, who I'm sure a lot of you know. He is such a mentor and a moral force behind a lot of this work. And our Fell Lab, which amazing. And we've been able to provide over 3,000 tests, 34 shelters at this point. I think what I'm hearing a lot of in this conversation also is about, you have a vision, you have a mission, you know that you want that. Ruth, I think you spoke to all of that. And then you have to listen, you have to pivot, you have to be a little iterative. And so we took an iterative design approach to this. We started in some communities, we started small, we build relationships. And without relationships, you can't go very far in this space. And we worked with homeless shelters, FQHCs, local health departments to really move this project off the ground. So all of you, just to this question of partnerships, Kathleen, how has that showed up in your work in that space of collaboration and partnership? And what does that mean in terms of addressing equity and social determinants of health?
I think there have been some really great partnerships that have shown up. And, not just by us, but I watch, many of my peer organizations just partnering with each other. For us, we are working much more closely with the local Department of Health. We run a health information exchange. I think that, of the many lessons of COVID, I think that this exposes how underinvested our local health departments are, our state health department is, right? That we have not made them operating organizations at a population level because of such underinvestment. And so we immediately, connected our health department. They called me on the Friday that we all, that Monday that everyone went into quarantine, the 16th or 17th, that Friday they called and said, can we get on your health information exchange? And we brought them on right away. By Monday, and created a record for them, and now have created an electronic health record for them. But just the idea that our local health departments are sitting out there in communities like Camden and Newark and Trenton that have major health systems, that have electronic medical records that we spend hundreds of millions of dollars on. And we literally do not have health records, electronic medical records in our health departments for them to be able to track COVID and the vaccine. It is just something that we've been trying to fill in that gap. And I think the other regional health hubs, at least some of them have been trying to do that. So that's one partnership, but let me let others answer.
Yeah, great. For Mark, what new partnerships have come your way in terms of providing funding, support, outreach? What has come up there?
So because we're laser focused on the ultimate goal of the self-healing community showing up in Passaic County, we know that that takes multi-sector, multi-level partnerships based on consensus, right? So right when the pandemic hit, so for March 9th, when we went into this mode, I especially started getting into the work of reaching out to our strategic partners and saying, I think the most important thing was saying, what do you need and how can we help? Not let's work together on this. It was, what do you need and how can we help? And that started to create the consensus. So ever since then, just right off the top of my head, partnering with 5 other organizations, we created a hospital distribution that served about 150 to 200 families a week at the first half of the pandemic. The food boxes were being distributed at the hospital. We established a network that was home delivering to about 191 families every other week. And these were COVID positive families that couldn't get out. And it was our organizations working together. Just in the last few weeks, we've relaunched our job readiness program, partnering with another organization to target young Black and Brown youth that need jobs, warehousing jobs. So at every level, we've started, and these are not new partnerships. These are partnerships that we knew we needed to get to. And to Kathleen's point, we just shift everything into overdrive and said, we're partnering now. You're not getting out of it. We're partnering now because we need to get better at this right now. The systems that we had in place are not working. They're breaking down. And I need you right next to me so we can get after this because people need our help right now.
Retha, for you, what new partnerships, how has the stakeholder landscape changed for your organization?
So actually, there's 3 levels of partnerships that are extremely important to us. First of all, we need to understand what people need on the ground, right? So we have to talk to people in communities to find out what they need and how soon that they need it. And so my major role is community engagement, right? And so I'm actually leading up a community engagement initiative now in which I'm working with community members across 6 cities. We've been talking to at least 81 to 100 people in the community, asking them, what is going on in your community? What do you need for your families? So I work specifically in youth justice. And so I'm specifically saying, what do we need to keep your young people in your community safe and to make them successful? And we're helping collectively actually to come up with solutions that they want to see in their community. So as an institute, we don't tell people, what the solution is. We have to ask people in the communities what that solution should be for them, and then engage them in making sure that the solutions that they come up with is what we implement. The second level, of course, is engaging young people in particular. So at the Institute, I lead up some young people in 2 youth coalitions or youth councils, one in Newark and one in Trenton. We have youth leaders that meet with them bi-weekly, and we're constantly talking to them about what are you feeling during COVID-19? What do you think you need? How can we help you? Important, if we're going to talk about youth justice, to make sure that those young people are engaged in the conversation. And I guess the last thing It's very important to have, a coalition of like-minded organizations who are trying to make sure that there are some policies that we put forward that are going to help folks in the community, right? So in order to get any policy passed, you can't go in alone. You have to build a coalition. So we have, 50 to 100 organizations that we can call on at any time to mobilize, to put, to put forth policy that's going to help people in the community.
Thank you, Rita. Moving forward and thinking about the future and what's out there, all of you just are such tremendous leaders and lead these adaptable, resilient nonprofit organizations. What advice do you have for nonprofits in this space moving forward? What lessons on leadership do you have in this space? Whoever wants to answer first.
I'll start.
Okay.
My advice as we all move forward through this together, ACEs and Kababa. I think every nonprofit, every social service organization, every health system, everybody should understand adverse childhood experiences, how that leads to toxic stress, how that leads to poor health in our communities, and how we can prevent ACEs by providing equitable opportunities to the individuals and families we're all trying to help. When you're trauma informed, it is a game changer. And there is a big difference between saying, I'm helping a poor person versus I am helping a person living in poverty. The first one is you trying to change a person. The second one is you trying to change a system, right? And I think Kababa, knowledge, attitude, belief, and behavior. We all need to really put ourselves on blast about tracking knowledge, attitude, belief, and behavior in how we do this work. Because the very hard truth is, well, there's two hard truths. One, it's very expensive and very challenging to do that when we do our programs. But two, if we are not effectively tracking that, as nonprofits especially, we could potentially be part of the problems we're trying to solve, right? Mm-hmm. And so this pandemic is bringing us face to face with some very hard questions, but I think they're the right questions that we need to be asking ourselves.
Thank you, Mark.
So what I would say is nonprofits really need to understand who they're working for, who they're servicing. I have to harp a lot on talking to people who you're working with and not thinking that you're, providing what you think they need. So it's extremely important to get out, establish relationships. Trust is extremely important. A lot of communities, particularly communities very hard hit by COVID-19, don't trust the system. And so the only way they're going to trust the system and trust you as a service provider is for you to get to know them and to understand them where they are and to understand their situations, understand what trauma they're going through. I mean, I recently called one of my advocates just to say, how are you doing? And, she told me really how was she doing, how she was doing. There was food insecurity. She was concerned about a young person, her son who was incarcerated. And so, you really need to take the time to figure out what they want and not just move forward and, with services as usual and not understand what people on the ground really need.
Kathleen, what are your thoughts?
I mean, I think that my colleagues on the panel sort of said it all. I mean, it's just really being, in tune with both your own staff and then with your clients and really, really listening. I can't remember the author now, but there's an author who does major biographies and he writes little SU to himself as he's doing interviews, so he doesn't talk too much. You see that little SU on my little note there to myself? We get in this work because we're really passionate and we have a lot to say, but we got to SU, we got to shut up and we got to listen And so I often tell my staff, like, go to that meeting. I want you to go to that meeting and I want you to say nothing. You earn the right to speak. So.
Thank you for that.
Sorry, can I just say thank you, Kathleen, for saying that. I love that, and I affirm what you're saying. So thank you for sharing that.
Thank you. To end, as Dr. Chris has ended on a note of hope, just a rapid fire, what gives each of you hope?
Hey, you know what I'm doing after this? I'm going to my office in a very socially distant way. I am packing up 85 baggies, and we have an Operation Santa, and we're taking baggies out to all of our staff all across Jersey and North Jersey to tell them thank you. So you know what? Like, I have run a deficit. I've been, all these sorts of things that have happened, but I have an embarrassment of riches when it comes to staff, and that gives me hope.
I'm laughing to myself because I wonder if our long pause as a panel as to the question of what gives you hope makes everybody think, oh no, there is no hope. there is absolutely hope. I think what gives me hope is that there is major opportunity to do better and to be better, especially for us in the anti-hunger space. There is major opportunity to see how the system really is not perfect and how we can at least try to make it perfect. So it gives me hope that we have a lot of partners that say, I am so down to work with you, Kumac, and try and be better together, because we all know we're not perfect. And I also found out I'm going to be a dad. So that gives me hope as well.
Congratulations. Woo. I don't know if I can top that one. So I think two things give me hope. My colleagues and volunteers that I work with every day give me hope. They are in the trenches. They are working hard. They are putting in long hours, trying to figure out ways to change the system. That gives me hope. Through this pandemic, we've moved policies. I mean, we've actually got some things changed. I mean, last week, the Attorney General announced a new station house adjustment policy that will allow young people to, connect into community services as opposed to going, being arrested and being incarcerated. So policies being passed during this time is giving me hope. And 2021 is giving me hope. And because we're about to leave this year, which has been crazy, and start a new year, and starting a new year always brings new energy. So 2021 gives me hope.
Beautiful.
Here.
Thank you all. You all give me hope. And turning it over to Darren for some questions from the audience.
Thank you very much, Natasha. And once again, you all give us hope for all the good work you're doing in your communities. And you all are a plethora of information. And we're hopeful that people will take advantage and look you up on your websites and send you emails and continue to have this level of dialogue. We do have time for at least one or two questions. And one of the questions that have made it to our chat is, so many times that you are, at least during the course of this conversation, you have mentioned several times about approaches. As we are understanding and further examining COVID response, COVID relief and recovery, how do we balance innovation and upstream approaches while we continue to understand the immediate needs right now in our community? And that question can go to any one of you, and we're promoting you, Natasha, as well, to a panelist.
I can start. I'll go with, I'll go back to what I was saying before. I think to balance it long-term and both short-term, being trauma-informed is super helpful. Long-term, it centers you on alleviating the burden of health as the main goal. And you can ask yourself long-term, is your intervention going to alleviate the burden of health on an individual, a family, or a community? Short-term, when you're trauma informed. You can look at the service you're providing, the intervention you are providing right in that moment and say, am I actually making you better? Have I moved the needle in making you better, even just a little bit, by you coming to me for help and for service? And I think just because we're in a pandemic doesn't excuse us from asking that question in the near term.
Kathleen, Retha, you have anything? Natasha?
I think some of the places where we need to innovate are around mechanisms to change how we get funding out and how we staff things up. I think that our state is, like most states I've worked with, really burdened by a procurement system that asks them to both do competitive process and which slows things down and often restrains who they can contract with. So, innovation there, like how do we get that? How do we do that differently? And innovate around indirects, right? Robert Wood Johnson Foundation was one of the first, foundations to say they're going to start giving 20% indirects to nonprofits, right? Some of that is the innovation we need to do. It is super boring, but is literally the structural stuff that gets in the way of doing some of the kind of work we want to do. So that innovation, procurement innovation, indirect innovation, we know a lot of the stuff we need to do on the ground. We're not staffed up to do it. I recently accepted doing a research project with someone for community health workers.
Yeah.
And they said that there was going to pay in the research grant was $35,000 a year. I said, well, my minimum salary is $42,000. So, I'm not sure what to tell you, but like, it's things like that we need to innovate around, like demanding salaries that meet, like, that are living, not just living wage, but that are above that. The living wage needs a COLA. So anyway.
So I think that I would answer by saying we need to innovate in how we use resources and funding. I mean, from a youth incarceration perspective, we're spending $300,000 per child to incarcerate young people. We're spending $54 million to operate 3 youth prisons that are half or less than half full. And so I think we need to look at ways to shift and move money and resources and funding so that we can support folks in the communities in a better way.
Thank you. And, as our families and our communities go through this tumultuous time, we know that nonprofits are struggling as well. As we have not received any federal relief, and we're hoping that, as Dr. Besser mentioned, we're hoping that perhaps our congressional leaders will eventually come together to provide some level of relief. As we are speaking, or I'm asking this question germane to your area of expertise for this panel discussion, how do we continue to strengthen our public health infrastructure and to help others not to see science in a malicious way, but to see science and the economy and other aspects interconnected as we work together to improve our society? So we'll leave you all 3 with that question.
I'm happy to start. On the public health side, I think there are some federal efforts underway to actually fund public health more like the way Medicaid is funded, which is on a per person basis, and not have our public health department have to be grant-based, constantly figuring out which grant they need to do next so that they can actually keep their staff, but do like a per population basis per person amount of money for public health, which would, I think, allow our community health departments and our state health departments staff up in a different way. So that's my answer.
I think for me, it's two fronts. partner well with our health systems. And when I mean partner well, as I say, for us as nonprofits, we have to be vocal about what we're seeing on the front lines and not be afraid of what the reactions might be. I think we have to be honest, open, and really say, let's really work together, health system, health expert, on what we're doing here. But then on the client and team side, for us at CUMAC, a really quick example is we administered flu shots for our team because working with one of our health system partners, we didn't want our staff getting a double dose of flu and COVID potentially. It took about 2 weeks of messaging. I had to talk to some of our team members from the community about what a flu shot is. I think we have to go down however many levels we can and speak to our clients and speak to our team members about our beliefs and where we're coming from. We talk about COVID-19.nj.gov at staff meetings as well, and we walk people through it. So I think those two fronts will help strengthen the public health infrastructure.
So I think we're going to need to look at forming coalitions that are across entities. I mean, not just looking at social services organizations, but we need to bring government officials in the discussion and the private sector. I mean, people are living lives that are complex. It's not just in one area. And I think, you know, the service providers can't do it alone. We're going to need to, you know, have more discussions with people who work in government, but we also need to have more discussions with people who, you know, who are running corporations and are in the private sector to figure out how to tackle this health issue.
Well, we can continue this conversation for a long time, but we have made it to the end of our hour. And once again, please join me in the planning committee. We're thanking each one of you, Rita, Mark, Kathleen, and Natasha. Thank you very much for inspiring conversation. We look forward to working with all of you, working with the greater public health community as we continue to provide relief and recovery to our families and those communities that suffered most by the hands of COVID. So thank you. Well, I hope everyone that joined us today had an enjoyable morning and time well spent. We have planned a full-day conference in April. However, more details will be forthcoming based on public health guidelines. Your safety and following science and public health is more important to us, and your safety is evenly more important to us. We also have a survey that if you take a look at the chat feature, there's a survey. We're asking for you to complete it. Should take about 5 or 10 minutes as we're looking for more insight, more content as we begin to prepare for a conference of some type in April. So please take a look at your chat feature and go directly into the Survey Monkey. Also for our New Jersey residents, we want to hear from you. Your story and experience matters. Please visit our website at www.njymca.org/community conversations for more information on how you can help shape policy and programs that support residents during and after this pandemic. And also for those of you that have registered for the Cost of Poverty experience, it will begin at 12:00 p.m. There is still space for some of those that would like to attend. We had a number of those that were registered said they were not available. So therefore we will extend that opportunity for those of you that are currently in the attendance of this conference. You'll be able to access using a separate link you received earlier this week, or it may have been through email or even a calendar invite. My colleague, Marissa Davis, will welcome you back and kick this experience off with Think Tank, our COPE training partner. And once again, this has been sponsored by RWJ Barnabas. So once again, thank you for joining us today. Thank you for inspiring us to be better, to do socially good work. You could have been any place today, but you chose to spend your time with us, and we are thankful. So be safe, be well. Do not forget to get your flu shot. Until then, You have a great day and you have a great holiday season.